next presentation will be for Dr. Matias Iglicki, that will present VIT-DEX study, vitrectomized versus non-vitrectomized patients and DEXA implant results. Matias.
Yeah, thank you so much. We are more than grateful, delighted, and thrilled for being here and present this beautiful study. Thank you, Marcio. Thank you, Fernando, and especially Fernando for teaching us how to do this. Let's see. So this study was conducted around the world from South America to Australia and from North America, the US, to Europe. These are my financial disclosures. This paper would not have been possible without the help of Professor Lowenstein, our mentor, and also the International Retina Group. The International Retina Group is a group that belongs to the world, and mostly every single country is represented here. I would like to thank Dean Azur, my co-author, my friend. We'll do everything together, and that's why we have very nice results. But again, I don't want to forget my co-authors, Jay Jablani from Pittsburgh, Anna from Spain, Daniel from Italy, Javier from Spain as well, Roberto from Spain, Giuseppe from Italy, Marco from Italy, Valentina from Italy as well, Professor Paulo Lanceta, who is here today with us, Samantha Freiserberg from Australia, Kata from Leipzig, Germany, Safer from Turkey, Carolina from Spain, now working in the UK, and Patricia from Spain as well. So going straight to the paper, we have this, how the DME is produced. We have two ways. One is the ischemic pathway, but one is the inflammation. And we were wondering what happened when the vitrectomy is out in those vitrectomized patients with DEX implant. Does the vitreous or the lack of vitreous impact the DEX implant efficacy and safety profile? Let's see what happened with this paper. So the idea was pretty easy, to inject DEX implant in every single patient, regardless if this patient is vitrectomized and not vitrectomized, and then check what happened in, again, the safety profile and the results, best corrected visual acuity, and also macular thickness. As you can see here, this patient is vitrectomized. That's why shortly after the intervention, you see DEX implant inferiorly. Taken from the paper, which was published in iJournal, very high impact factor journal in the field, you can see this patient has vitreous. That's why you can see the DEX implant shortly after the injection maintained is superior. On the other hand, a vitrectomized patient, you can see shortly after the intervention, the DEX implant lays inferiorly due to the lack of vitreous. As I say, we have this paper published. Again, thank you for every single co-author. And the idea was to compare visual and anatomical outcomes in vitrectomized and non-vitrectomized eyes, and also when we use DEX implant for diabetic macular edema. Let's go straight to baseline characteristics. As you can see here, we have more than 236 eyes, and it was very well balanced, the baseline characteristics. Even we have a little bit of statistical significant difference in CMT at the beginning. But let me go straight to the results. As you can see here, there is no statistical significant difference, neither in best corrected visual acuity nor in CST changes. What about safety profile? We didn't find any difference, and this was very important. But what about best corrected visual acuity? As you can see here, the p-value is not a statistically significant difference in both groups. And again, the OCT measurements as well, no statistically significant, and the same thing happened with safety profile. So we were wondering what happened with these patients. These papers open a very nice door for a randomized clinical trial in order to realize the current impact of vitrectomy in these patients. But as conclusion, we can say that we demonstrated with this beautiful paper the similar anatomical and functional efficacy of DEX implant in non-vitrectomized and vitrectomized eyes was shown. Its efficacy was not influenced by full vitrectomy for diabetic retinopathy complications. And the safety profile was very well balanced between groups. Having said that, I would like to thank you so much on behalf of the International Retina Group. Thank you.
nice paper. Open for questions.
Michael Singer, San Antonio, Texas, United States. Spectacular paper. I had a question. So when patients needed to be rescued, let's put not rescued, they started to swell up, and what did you use for rescue? And if you gave an anti-VEGF medication, did it last longer or the same amount of time in both groups, or what? Let's start with that.
Awesome question. Thank you so much for asking that. So we were asking with Dina how to answer this question, and we have been doing research about this. Certainly, the lack of video when we inject anti-VEGF, the clearance is much faster. We are not saying that anti-VEGF, all of them, they do not work in these vitrectomized patients. We are saying, and this has been published, that the anti-VEGF is washing out more frequently, faster. So if we want to try this patient with anti-VEGF, we have to be very careful and do it more frequently. So this is a fair question. I think you agree with that the clearance is much faster. On the other hand, when we rescued this patient in this paper, we didn't have to do that because the follow-up, and this is a limitation, is way too short. It's only 1 year. So we are now looking at the second year of these patients and how many injections and which one we have to rescue from that. So this is my answer. So, but you have maybe some more comments about this.
I mean, so one of the questions is, we all know diabetes is multifactorial, right? I mean, it's one of the things that we all agree on. It's both VEGF mediated and inflammatory mediated. And having a steroid on board means the anti-VEGF really doesn't have to fight 2 battles. It only has to fight 1. And in the extended steroids, like things like Iluvien or fluocinolone, when people give anti-VEGF medicine when they need to go, it lasts longer. In the vitrectomized patients, Barry did all this great work showing that the rate of release is the same. Did you find the similar response that we know it? Obviously we know it lasts shorter because it's vitrectomized.
Yeah.
But does it last longer because it only has to play the VEGF game?
Very good question. Again, we didn't find any differences in the lasting of the treatment. We didn't use Iluvien in this case, or fluocinolone, so we only used Dexitat, but we didn't find any statistical significant difference in the first year regarding the lasting of the treatment or the effect, if I can say that, answering your question.
Sounds great.
Well,
Thank
we
you so
could
much.
be discussing for a long time here, but I'm sorry, we have to close the
Just to say
session.
that this is a success in what you're saying, and that in a vitrectomized eye there was really no difference from a non-vitrectomized eye, and that's different from a drug delivery standpoint than normal free injections of drug, I think is another conclusion.
I agree with you, and I think for our perspective and in our real life settings, if we see one patient that is vitrectomized, we will go straight with Dex implants.
That's one of the implications. Just want to understand that.
Thank you so much, Barry. Thank you so much for your comments. Thank you, Fernando. Thank you, Mauricio.
Thank you
so much.
Thank you so much, Matias.